I think a lot got presented that was clinically meaningful and impactful in terms of changes in our treatment practices in clinic right after ASH finishes. So some of the studies that I'd like to highlight would be, of course, some of the follow-up data that we saw. For example, on the POLARIX study, which we saw the 5-year POLARIX data, which continues to show a benefit of POLAR-CHP compared to R-CHOP alone. That basically translated into a 5-year overall progression-free survival of 65% versus on the R-CHOP arm under 60%. So the benefit was certainly more pronounced in the non-GC subset. At this point in time, overall survival benefit is not seen, but that could be a function of later lines of treatment that we have that also have a curative potential. The 5-year POLARIX data definitely consolidates my approach of treating advanced stage patients in the frontline setting with R-CHP POLA if they have an IPI of 2 and above. Besides that, the AMPLIFY study in CLL that was presented, in my opinion, is also practice-changing. It was a study in patients with CLL who needed upfront treatment, randomized to either acalabrutinib plus venetoclax in a time-limited fashion, acalabrutinib plus venetoclax plus obinutuzumab in a time-limited fashion, or chemo treatments. Obviously, it was expected that chemotherapy did not perform as well as compared to targeted agents, but I think this analysis was really helpful in understanding the 3-year PFS with a time-limited approach in patients with CLL. They were not TP53 aberrated. As a result, it's really important to focus on the non-TP53 aberrated CLL patients who were treated with A plus V or A plus V plus O. It was very impressive to see that the 3-year PFS was excellent. There were many patients after completion of the regimen who enjoy a treatment-free period. On the A plus V plus O arm, we see slightly more infections and definitely COVID-19 related infections. So at this point in time, I'm hopeful that it could get a regulatory label so that we could use it as one of the other treatments for our patients with newly diagnosed CLL. In terms of other promising data that was presented at ASH, I was I thought that the loncastuximab plus rituximab combination that was tested by Dr. Alderuccio in relapsed refractory follicular lymphoma was exceptional and showed very high responses. Similarly, the AZD CD19 bispecific T-cell engager in both follicular lymphoma, relapsed refractory follicular lymphoma, as well as relapsed refractory diffuse large B-cell lymphoma looks very promising, so something to watch out for. And then there were obviously the follow-up studies that got presented, for example, the Transcend FL data at the 2-year mark with Lysocell, which continues to demonstrate excellent outcomes and good efficacy with manageable toxicity profile for patients with relapsed refractory follicular lymphoma in the 2nd line as well as in the 3rd line setting. So I think that regimen, that CAR-T construct is definitely something that seems to be outperforming a lot of other treatment options that we have for relapsed refractory follicular lymphoma. And then towards the end, I think the 5-year follow-up of the Transcend NHL 001 study was also presented by my colleague, Dr. Jeremy Abramson, in patients with relapsed refractory non-Hodgkin lymphoma in the 3rd line setting. Really impressive to see that at the 5-year mark, the durability, the outcomes, the duration of response, the disease-specific survival is exceptional. The toxicity profile is very manageable. There were no new toxicity signals seen. Less than 10% of patients had second primary malignancies at this point, with no patients having T-cell lymphoma as a second primary malignancy. Overall, the 5-year data suggests that Lysocell has a curative potential in the 3rd line setting for patients with relapsed refractory non-Hodgkin lymphoma.
I think that ASH this year, when it comes to novel trials for the treatment of relapsed refractory follicular lymphoma, there's been a clear message that it's time to finally target more CD19. We already target CD19 in follicular lymphoma with CAR T cells, but due to toxicity, the penetration of CAR T cell therapy in follicular lymphoma is currently very limited in US and Europe. But there are 3 trials, a phase 1 trial, a phase 2, and a randomized phase 3, showing that 3 different products, all targeting in different ways CD19, can be very effective in this patient population. The first one is a phase 1 of a bispecific antibody targeting CD3 and CD19 owned by AstraZeneca. In this phase 1 study, the safety profile was quite acceptable with low rates of CRS and immune cell-associated neurotoxicity syndrome, and very high response rates were observed in a heavily pretreated follicular lymphoma population. The subsequent study was a multi-center phase 2 study based on very promising data that Dr. Alderuccio presented last year from the original phase 1, showing that the combination of loncastuximab, an antibody drug conjugate targeting CD19, and rituximab can be highly effective for patients with relapsed refractory follicular lymphoma. And finally, a randomized phase 3 trial will be presented by Dr. Lori Sen as a late abstract on Tuesday morning, showing that the combination of tafasitamab, a monoclonal antibody targeting CD19, and lenalidomide performs significantly better with significantly longer progression-free survival and even an initial trend for longer overall survival as compared to R-square in patients with relapsed refractory follicular lymphoma. So over the last years, our focus in follicular lymphoma has been targeting CD20 with the introduction of anti-CD3, CD20 bispecific antibodies. I think the trend from this ASH is quite evident, and the overall therapeutic landscape may meaningfully change in the next year.
At least in large cell lymphoma, there are several studies of trying to make R-CHOP better still. So we know POLARIX was polar-R-CHP, and it was a PFS benefit, still no overall survival benefit. But there are several studies now looking at bispecifics plus R-CHOP or bispecifics plus polar-R-CHP. Also, CELMoDs plus R-CHOP. There's a frontline study which is looking at Lentafa plus CHOP in this patient population. So there are several frontline studies that should be reading out fairly soon with large cell lymphoma, so that maybe we can actually get some sort of idea of what is the true standard of care in this patient population. Additionally, if we look in follicular lymphoma, I believe there's several trials ongoing that are looking to build upon the R-square backbone, at least in second-line follicular lymphoma. And then we will likely start to see some of these bispecifics move into the front line with follicular lymphoma, either together or as single agents going against chemoimmunotherapy.
So a lot of exciting things happening in the relapse refractory setting in mantle cell lymphoma in terms of what I would say are going to be potentially practice-changing trials. 2 that I would highlight. We have the GLOBRYTE trial. GLOBRYTE is a phase 3 study that's being done globally that randomizes patients to glofitamab, a CD3, CD20 bispecific antibody in relapse refractory mantle cell, or to investigators' choice of either chemotherapy or lenalidomide and rituximab. So that study, I think, is going to really help define for us where should we be using bispecific antibodies in mantle cell lymphoma. Another trial that I'll highlight is the BRUIN MCL-321 study. That's a phase 3 study of a non-covalent BTK inhibitor, pirtobrutinib. Pirtobrutinib is currently approved in patients who have had a covalent BTK inhibitor, but the 321 study is a head-to-head comparison of pirtobrutinib to investigators' choice of covalent BTK inhibitors, so ibrutinib, acalabrutinib, or zanubrutinib in patients with relapsed refractory mantle cell, and that will also help us to further define where should we be positioning pirtobrutinib. So these are studies that we're going to really pay attention to and want to see those readouts from when they're ready.
Yeah, so lots of interesting data has come out in diffuse large B-cell lymphoma. I would say a session that sort of perked my eyes was the R-CHOP plus X. So there are so many combinations being developed in the frontline setting of R-CHOP plus a ROR1 inhibitor, R-CHOP plus a PI3 kinase. And having sat through that session, what I would simply tell you is the data look impeccable, that we are able to add drugs to R-CHOP, which may potentially change the efficacy and the frontline standard of care. All of these drugs are being now tested in a phase 3 clinical trial, and this includes bispecific combinations with R-CHOP. So in a couple of years, we're going to see the readout, but what I'll say is that early phase 1-2 data looks really promising. The other thing that I thought was interesting is the 5-year outcomes of the POLARIX data, and I think this is something that all oncologists want to look at, is did polatuzumab continue to show benefits to patients if we give it as part of frontline treatment? And the short answer is yes. Even at 5 years, there was a persistent progression-free survival benefit. Less patients needed more lymphoma treatments if they got POLA-R-CHP, and less patients died when they got POLA-R-CHP of lymphoma-related progressive disease. And so highlighting a few things here, there's lots of other stuff that happened at ASH 2024, but I think for those people treating DLBCL, some interesting things to keep an eye on.